We'll start our post-lunch
No,
session with laryngology, that is benign and malignant vocal fold lesions. Moderator Dr. Manoj Mukherjee. The other panelists are Dr. Soumitra Ghosh, Dr. Ati Sallar, Dr. Soumitra Kumar and Dr. Shantanu Seet. I request Dr. Manoj Mukherjee, please take the mic and proceed further.
Yeah. Hello. Yeah. So, good afternoon. Finished your lunch? Yeah. So, you have swallowed so many food and nothing gone inside your larynx. Huh? That's a miracle, I think. You are having a oral cavity and there is a huge laryngeal inlet just below and behind your oral cavity, but still food is not going there. Huh? So, you all know the swallowing mechanism. This is not our topic, just it is a post-lunch session. So, our topic is benign and malignant vocal fold lesion. You all know it is a huge topic. It is a huge topic and we can think or we can imagine about covering it within a 1 hour spell. So, what we will do? We just focus on postgraduate examination, MS examination. There is very specific questions which is asked by the examiner. We will just highlight the question, we will expect some answer from you and we will guide you answer. So, our discussion will be restricted on MS exam orientation. This is not a theory class. So, with us, with me, we are very eminent doctors and medical education from medical educations. Dr. Ati Sallar, anything wrong? And he will describe on the diagnosis or investigations. Then you have to differentiate between the benign and malignant lesion. That is a very important part of any laryngeal case which you will have in your MS exam. How will you differentiate between a benign and malignant lesion, because that carries different significance. Next, management part will be described by Dr. Soumitra Ghosh. He is a laryngologist basically, and specimen that will be described by Dr. Shantanu Seet. So, to begin with, a 38 years male patient presented with hoarseness for 3 months, but there is no dysphagia. Carpenter by profession, smoker, 1 pack per day, you all know the significance, and there is no systemic illness. Voice assessment, I told it's hoarseness. Different types of voice are there. Can you name can you tell how to assess the voice? Microphone? Yeah. Any other assessment method? Voice assessment? Voice handicap index and GRBS, fine. So, there is subjective method and objective method. In subjective, many methods are there. Most commonly used are voice handicap index. This is questionnaire based, self-answered questionnaire based method. And in the objective assessment method, so many investigations are there. Most commonly practiced one is the GRBAS, because this is very simple and any trained person can assess the voice by GRBS method. GRBS, that is G stands for overall gradation, R for the roughness, that is irregularity in movement of the vocal cord, B for the breathy, that is leakage of air in the glottis, and A for the asthenia, that is weakness of the voice, and last one is the strain, that is hyper-functioning state of phonation. And in this 5 category, there is a normal 0 point, slight deviation 1, moderate deviation 2, and extreme deviation from 1 is the 3 point. So, accordingly you can scale the voice problem objectively of any patient. Detailed history, chief complaint, and from there you have to go for the detailed history. We are not going in that part. Temporal relationship among the chief complaint, that is hoarseness, dysphagia, lump sensation, stridor and neck nodes. Say patient presented with the hoarseness of voice developed dysphagia after 1 year. What does it signify? Malignancy, vocal cord, then malignancy of vocal cord, then why dysphagia? Hypopharyngeal extension, very good. And reverse, the patient presented with the dysphagia, now developing the hoarseness of voice. So, it is a temporal relation between the chief complaint that will be asked if you get the CA larynx case. Thorough examination, you all know the laryngeal, I am not going in details, laryngeal palpation. কি দেখবে তুমি মাইক্রোফোনটা কার কাছে আছে হ্যাঁ তুমি বলো laryngeal palpation এ কি দেখবে
laryngeal crepitus is there
yes and splaying of the thyroid cartilage. And what is laryngeal crepitus?
We move the cricoid cartilage over the critical fascia. If
Yeah.
there is crepitus is present, then is Broca's sign
Okay.
positive. I have sent an
Fine, fine, thank you. So, in laryngeal palpation, broadening or splaying of the thyroid cartilage, and there is a laryngeal crepitus that is called Broca's sign. In crepitus, you have to know what is crepitus, how it is produced, and what is the importance of laryngeal crepitus. তুমি বলতো what is importance of laryngeal crepitus? Post cricoid space or prevertebral area. That is not only the carcinoma, you may, that crepitus may be lost in retropharyngeal abscess also. In IL, I am not going in details, there is an undergraduate question. So, fiber optic of the IL example, what to see, extent, movement of the vocal cord and all these things. Video stroboscopy of the patient, এটা বোধহয় চলবে না anyway. So, in FOL we have found this type of lesion, bilateral vocal cord keratosis. So, our diagnosis is bilateral keratosis of the vocal cord. It can go either way. It may be benign, it may turn up to be a malignant lesion. So, how will you arrive at your diagnosis? The bilateral keratosis of the vocal cord, there is chances to be benign or malignant. So, you have to arrive at your diagnosis. How will you diagnose it? Apart from clinical symptoms, you need the investigations. কার কাছে মাইক আছে? So, কে বলবে যারা বেশি কথা বলছে না বলো, what are the investigations for particular this patient? Laryngoscopy, FOL, it's very common. Then
video stroboscopy.
Yes.
Then sir biopsy.
Biopsy, there is a gold standard, and apart from that, narrowband imaging, so many upcoming investigations are there, but don't forget the CT scan. Imaging, that is the most CT and MRI. So, that part, there is an investigation part that will be taken care by our faculty, Dr. Atish Haldar. Please, Atish, please.
I am Dr. Atish Haldar, Professor and Head, Purulia Medical College. Every time, in every examination, you will get a case of laryngeal lesion, and you have to answer something. Every examiner, in your examination, ask you, what are the investigation will you prefer in a case of laryngeal lesion? Every examiner. You can easily tell, the student also tell us that fiber optic laryngoscopy, video stroboscopy, CT scan, he forget CT scan, MRI, direct laryngoscopy, biopsy. Everything you can easily tell us. But you will utter the word high definition camera imaging, narrowband imaging, and the old obsolete ultrasonography or PET scan and newer voice chymography. It will carry extra marks in your mark sheet. Don't forget to answer this. Now, I briefly describe the investigation What is fiber optic laryngoscopy? It helps us.
কাছে
Oh, sorry. For real-time imaging of the larynx and the surrounding structure, help us to diagnose the voice disorder. Examiner always asks that, what will you find? What the use of fiber optic laryngoscopy? You have to tell, it can help us to diagnose the voice disorder, swallowing disorder, breathing problems. We can easily assess the tumor and growth and evaluation of larynx after surgery and before intubation, pre-anesthetic for checkup. And there may be some discomfort during the scope insertion. But now the video stroboscopy, which law it follows? Is follows Talbot law. If you answer better, some examiner will ask you. It will follow Talbot law. It emits rapid flash of light synchronized with the patient's vocal fold vibration. This creates an illusion of slow motion, allowing for detailed observation. It provides us information about the vocal fold vibration, including the symmetry, periodicity, amplitude and mucosal waves. Loss of mucosal waves signify deeper involvement, commonly seen in malignant and pre-malignant lesion. Now, high definition camera imaging. What is that? It provides us the accurate tracing of the each vibratory cycle and enables the visualization of the phonatory gesture such as voice onset and offset. Voice onset and offset, you can find that. This provides us clear visualization of the initial movement of the vocal fold from resting position to the phonatory vibration. Because during phonation there are vibration of the mucosal wave. Always do fiber optic laryngoscopy through nose. But because this creates the most favorable condition for observation of the physiological manner of voicing. If you insert the scope through oral cavity, you have to pull out the tongue, and this loss the physiological movement of the larynx and physiology of the larynx. Narrowband imaging, a newer one. It is the optical imaging technique used to enhance the visualization of the larynx, medial mucosal surface and microvasculature. Two types of lights used, blue light 415 nanometer and green light 540 nanometer. It enhances the contrast between the blood vessels and surrounding tissue, making subtle vasculature change more visible. I will provide some slides after that. What is that? It helps us to abnormal vascular pattern, neoangiogenesis. In every lesion, there should be new vascular formation or new angiogenesis. It differentiates the neoangiogenesis and differentiates the precancerous and cancerous lesion from the normal one. And during surgery, it helps us to assess the extent of the tumor resection margin, and we can provide the clear margin with the help of this narrowband imaging. The most important advantage is non-invasive procedure. You can see here the slides in the white light by direct fiber optic laryngoscopy and with the narrowband imaging. You can clearly differentiate the lesion, pre-cancer and cancer lesion with the narrowband imaging. Upper one is the narrow white light and lower one with the narrowband. CT scan. You should be provided with a CT scan plate and you have to answer it. Mostly of the CT scan of the temporal bone or the larynx. PNS CT seldom you will get. Very few will get CT scan of the nose and paranasal sinuses. So, it's the excellent modality to evaluate the submucosal space, and every time in a laryngeal case, the CT scan doing in the abducted position where the patient taking quiet respiration. It helps us to see the two vocal cord, anterior and posterior position. Contrast CT helps us to assessment of the nodes involvement. It helps us for relationship with the tumor, with the ventricular complex, subglottic extension, pre-epiglottic space involvement, anterior posterior commissure extension of the glottic tumor, laryngeal cartilage inversion. Always CT scan underdiagnosed because it can't provide us information about the pericordial inversion. MRI is better, but MRI also provide overdiagnosed. Some edema in the pericordium of the cartilages, you will think that this may be a cancerous lesion or involvement of the extralaryngeal tissue. These are few pictures. You should look and think when you get a CT scan from in your Viva table. Where you have to see. First one, the supraglottis level at the level of vocal cord. You will get this type of picture. And at the glottic level, you will get this type of picture. Now, next one. This one, the right glottic tumor to the ventricle. And this one, if this type of CT scan you will get, you should think that it's a stage 3 carcinoma larynx because it involves the pre-epiglottic space. Pre-epiglottic space. Here, left supraglottic carcinoma with paraglottic space involvement. You will find this type of CT. And next one, you should look after the cartilage inversion, which I previously tell you. The arrow showing the cartilage inversion. MRI does not use ionizing radiation. It's better for soft tissue contrast, which is crucial for visualizing the larynx and surrounding structure like muscle, ligament, cartilage and extralaryngeal spread. And cerebral and regarding laryngeal cancer, after treatment and after surgery or radiation, we can easily differentiate it by MRI scan. There are two pictures, T1 weighted and T2 weighted. First one T1, next one T2 weighted. You can find that supraglottic carcinoma. And here the glottic tumor, T1 and T2 weighted scan. PET scan used in staging, treatment planning and monitoring. Staging, treatment planning and monitoring. After operation, you can assess if there is any residual tumor present or not. When you will prescribe PET scan, minimum 3 weeks after surgery. Minimum 3 weeks after surgery. Ultrasonography, obsolete on. Old teachers want to know, do you know anything about ultrasonography? You should tell them, yes, it's a non-invasive procedure, real-time imaging. We can assess size, extent of tumor, any cyst, and in a case of high needle aspiration, the USG guided FNAC is better than other. Because CT guided always provide some type of radiation. Direct laryngoscopy should be performed in every case for proper visualization and for taking biopsy. And it also help us for inserting the breathing tube. Biopsy and Next investigation after biopsy is the histopathological examination. Now I call Dr. Soumitra to proceed further. Thank you.
Yeah, now you have to differentiate that thing, how to diagnose the malignant lesion from benign one.
Okay, so I think all of you know how to do a direct laryngoscopy. Can one of you tell me the most important failure of a direct laryngoscopy? You have taken, you have done a direct laryngoscopy, you have done a biopsy. What is the most important cause of failure? Have you ever faced such a situation that your biopsy came negative?
If it's not taken with adequate depth.
So one is not taken with adequate depth. Anything else? Anyone else? Okay, so not taken from the representative area. Okay, so that is one important cause of failure of a direct laryngoscopy and a biopsy. Now that is what I will want to explain in my slides. But first I would like to show you this, that this is a statutory disclaimer that biopsy is the gold standard for diagnosis. Okay, all of these can give you an idea, but after all you have to do a biopsy because that is diagnostic. But to help in your biopsy, that where to take the biopsy from so that it doesn't come negative, and if you are excising a lesion, whether you are excising the proper lesion in toto and you are taking adequate margins, for that you need some guidance that will give you the differentiation between the benign and the malignant areas. One of the easiest of this, these are the points I know all of you know that what is the history in a benign case, what is the history in a malignant case, what are the causes. I will not go into details of this. Symptoms also, just to reiterate that the hoarseness will be fluctuating type in benign. It may be normal in the intervening periods, but in malignant it will probably be a persistent or a progressive hoarseness. Appearance is also quite known to you that benign will generally be smooth, it will be mucosa lined, but a malignant one will have a ulcerated surface. Now there are some important chemicals which actually stain the malignant tissues better than the benign tissues. These are used in telling you that which area to biopsy and which area to excise when you are dealing with a lesion which is on the borderline. It is not exactly malignant or it is not also looking benign. Toluidine blue is one of the most historical markers. It is used, and and I always tell my students that the MS examination is actually a game of numbers, and you have to answer in different numbers. In the morning you were answering about Bethesda classification, about thyroids, and they were asking you that what is the percentage of malignancy in these cases. So here also they will ask you that what is the sensitivity, what is the specificity. So you have to remember these, that it has a 91 sensitivity. Just to tell you that these have a high sensitivity, but the specificity is less. That is, it will tell you that many things are probably malignant, but many of them may be benign also. The most prominent of them will be due to scarring and due to inflammation. Contact endoscopy. Now these things, this contact endoscopy and autofluorescence, these have been recent advances for the last 20 years. When I was a PG student, it was a recent advance. Even today, it is a recent advance. It has not advanced more than a recent advance. So these are things which have a dubious character. That is, they are not being used so frequently, like a CT scan or MRI probably. So this is something you have to remember, that these are not very diagnostic, but they can only give you a clue. Now what is done in a contact endoscopy? You bring the endoscope very close to the mucosal surface. Sometimes you touch the mucosal surface also, but you don't invade the mucosal surface. So these are non-invasive, but you have to get a good magnification. You get a magnification of the surface, and that is almost 60 to 150x. And with methylene blue staining, sometimes with toluidine iodine also, we do a staining, and this provides histologic information. It doesn't give you a histology. It's a histologic information. You have to correlate with the histology. And what we assess the vascular patterns. As you know that neovascularization is the hallmark of malignancy. And if you find that neovascularization, there are blood vessels which were not supposed to be there, you think that this is a malignancy. But there are limitations because you cannot go too deep into the tissue because you are watching it from outside. So too deep is not done. That is why it is inadequate for very deep lesions. And the observer also has to be very experienced for doing a contact endoscopy. Now, human tissues, they exhibit different types of fluorescence because they reflect different wavelengths of light at different wavelengths. Now, because of this, different parts of the cell, they give you fluorescence. We can induce fluorescence in tissues. There is two types of fluorescence. One is autofluorescence and one is induced fluorescence. Induced fluorescence means you give a chemical something and then you shine a light of a specific wavelength. From that, there will be fluorescence. Here also, the limitations are the false positive and false negatives are much more due to scarring inflammation and hyperkeratotic lesions. 5-ALA is the chemical which is most commonly used and it is applied by nebulization 1 to 2 hours before the examination is done. You nebulize the patient with 5-ALA and after that you shine a light of 350 nanometer wavelength through the laryngoscope and then you look for the fluorescence. And here also you see that only one study with 16 patients was done. The sensitivity was quite high, but the specificity was not so much. So this slide also says the same thing. Now there is another modality which is compact endoscopy, where you do a contact endoscopy as well as you do a fluorescence study. So when you combine these two, it becomes a compact endoscopy. So it actually tries to use the advantages of both, of the contact endoscopy and the fluorescence, and to cut down on the limitations. But here also the limitations are the same, the scarring and inflamed areas. Optical coherence tomography. This is also same thing. It is almost like a contact endoscopy, but here it uses light. The compact endoscopy does not use light, contact endoscopy, but here it uses light. And this has also a limitation that greater than 2 millimeter depth you cannot assess. So this is very good for carcinoma in situ or very superficial lesions. But for deeper lesions, it is difficult to say whether you are doing the right thing or not. But for diagnosis of very small epithelial lesions and for seeing a larynx in follow-up, you have done probably a laser surgery or a cordectomy or like that, and then you are assessing the larynx post-op. For these lesions, OCT is very good because it's a non-invasive procedure. So I will hand over the mic to Dr. Soumitra Ghosh for the treatment protocol.
Hello, can you hear me? Well, so see, this is not about taking a class. For the next 10 minutes, I would like to brush up what all of you are studying day in and day out. And please feel free to raise your hand and ask me any question at any time. You can stop me and ask questions. I'll be happy to answer and clear your doubts. So basically we are discussing a case of a vocal fold lesion. Think of the entire spectrum. We have a benign spectrum, we have a malignant spectrum, but the main problem is with the intermediate spectrum. For the benign spectrum, we have called the vocal fold nodules, the polyps, the cyst, sulci and mucosal bridge, all three come in the same family. For the vocal fold nodules, 90% of them usually they resolve by conservative management and lifestyle modifications. 10% require surgery when they do not follow what you advise and when they are really stubborn. For polyps, yes, usually for polyps and cysts, usually they require a surgical intervention. For sulcus, all of you know there are different types of sulcus, 1, 2 and 3. Usually type 1 and type 2 do not require surgery. Some subsets of type 2 and type 3 require surgical intervention. The malignant ones, yes, they require surgery. Type 1 Type 2A, you can address endolaryngally. Type 2B and the advanced cases, some group of surgeons, they are addressing it endolaryngally, or else you have to do an open surgery. So after me, the next speaker will take up that. In a generalized condition, how do you manage these patients? So this is a generalized slide for all of these patients. Do you straight away go to surgery, or you do some amount of conservative management? If it's a benign, you have already done your endoscopies, your stroboscopies. If it's a benign, you go with some conservative managements. And what are those? The first is the vocal hygiene. You have to take a good account of the history and inquire the phonation time, what the patient does, and how much degree about the hydration. Can anyone tell why is hydration important for phonation? Sorry? Absolutely fine. So how much would you advise the patient hydration? 3.5 to 4 liters per day. Voice therapy, is it required in all the patients? No. Some patients. How do you know the patient requires voice therapy? Do you know anything known as muscle tension dysphonia? So no, spasmodic is different from muscle tension. Muscle tension dysphonia is a tension in the extralaryngeal muscles which occurs due to the faulty technique of phonation or extra phonation on part of the patient. Spasmodic dysphonia is entirely a neurolaryngeal situation which has got adductor spasmodic, abductor spasmodic and mixed variety. That is entirely different. Now these benign vocal fold lesions, most of them have some degree of muscle tension dysphonia. Either it can be primary or secondary. Think of a polyp. Either the patient phonates too much of hitting of the vocal folds, you get a polyp. Or there's a congenital cyst, the faulty degree of phonation gives rise to a secondary muscle tension dysphonia. So you have to assess, as we have already discussed, the palpation of the larynx, you can definitely make out where there is some amount of muscle tension dysphonia. Why is voice therapy important? Because if you do not rectify the phonation pattern of the patient, even if you chop up the vocal fold nodule or the polyp, they will come back in 1 year's time. So vocal hygiene, voice therapy, hydration and reflux. It is written in the books 60 to 70% of these voice problems are attributed to reflux problems. So now you have settled with your patient, you have given a good amount of therapy and the patient is prepared for surgery. For this patient of bilateral keratosis, do you think the patient will require a surgery? Yes or no? Yes. So this patient will require a surgery. So either you can use a cold still or you can use a laser. We know that very well. Do you do anything to the patient after the surgery? Do you follow up the surgery? Again, in a broader term, yes. You give them vocal rest and voice therapy. For how long? Previously, when we were students, it was 7 days. Now it has come down to 2 days, to a maximum of 3 days of voice therapy and absolute voice rest and voice therapy. Again, the same vocal hygiene and the reflux management. Let us move on to the next slide. So I have already discussed this vocal hygiene, voice therapy, hydration and reflux management usually for 3 to 6 months. Now your patient is prepared for a microlaryngeal surgery. So what should be the position of the patient? Can anyone tell me? Okay, I am coming to that. So we will discuss on the position of the patient, anesthesia, whether you can do it in an office procedure or in-house procedure, instrumentations, and what precautions you should take during the surgery. The first thing is the microlaryngeal surgery. You know that all of you have done it with cold steel. Now for the laser assisted microsurgery of the vocal folds, what laser is used? Do you use KTP laser? When and where? For angiomatous lesions of the vocal fold, you can do a KTP laser. It usually doubles the wavelength of the ND-YAG laser by using KTP crystals. Frozen section. Where do you do a frozen section? Is it at all required for microlaryngeal surgeries? Yes, very good. Mike, yes. You should go for a frozen section. So for this patient, you are doing a microlaryngeal surgery, suppose with a laser, and you send that specimen for frozen. Now what if the frozen margin comes positive? How much tissue do you resect when one of your margins come out to be positive?
So ideally 1 millimeter margin
No,
is
it is 2 millimeters. So send your, again another question, how do you send these specimens, particularly in this patient of keratosis, basically you are doing a type 1 cordectomy. How do you send this, the examiner may ask you, how do you send this specimen to the pathologist for your frozen section? Do you send it in a vial with normal saline or formal saline?
no sir.
No. Then how is it sent? Yes?
Sir, we send it in a thin slice of cucumber.
Cucumber, okay. You can use a cucumber on an apple or whatever.
Yes.
But how is it sent?
Sir, we used 2 rubber bands and we mark it as right and the left cord, and the lesion is placed just wherever the lesion has been extracted from along that cord.
Okay, আমি শেষ করে দিচ্ছি এক্ষুনি. Yeah, you fix it, you mark it and then send it to the pathologist. So previously this was the position of the patient. We used to put something under the head, but now we put it flat. We put the patient flat. Anesthesia, can you do this under office procedures? Not this patient, but you can use isolated patients with a side port in a flexible and do office procedures. For the general anesthesia, you may be asked about the tubes. Do you know what is MLT tubes or microlaryngeal tubes? What is the difference? It may be asked in the question. Now these MLT tubes are thinner tubes with bigger bulbs so that you have got more areas to operate. Any idea about laser tubes? Laser tubes are armored tubes. Why? To prevent tear wafer. Absolutely fine. If you do not have an armored tube, how do you do a laser surgery? You either drape it or you put in anyway, so you know the laser safeties, you need the goggles, the anesthesia. Last question about the laser, what anesthesia is given in laser? Air, you give air. So again the normal standard postoperative management that we give in the preoperative. One question, does stroboscopy help in the postoperative period? How does stroboscopy help in the postoperative period? If you see that mucosal waves are not there, you know that there is again infiltration of the vocal folds. So you know that probably that malignancy is coming back. So last slide from my side is the cordectomies. We have to know all the cordectomies, type 1, type 2, type 3, type 4, type 5 for endolaryngeal lesions. Type 1 is subepithelial cordectomy. I think all of you have gone through this. You have to go through this. Type 2 is a subligamental cordectomy where you go up to the ligament. Type 3 is a transmuscular where you remove the thyroid muscle. Type 4 is a complete cordectomy where you go up to the thyroid cartilage, and type 5, the extended cordectomy. There are 4 subcategories. 5A where it extends to the contralateral vocal fold with the anterior commissure excision. Type 5B, I think we have all gone through this. Excision involves the arytenoid. Type 5C is where they involve the ventricular band up to the subglottis, and type 5D is it involves the subglottis as well. I think I will hand over to Dr. Manoj Mukherjee for the next, where now we discuss about when the lesion is going outside the larynx.
A slide. Hello. No, time. So generally the cases given in exam is a carcinoma larynx, a straightforward case, and you have to face the examiner. You must know all this part. Because of the time constant, I am not going in overview surgical anatomy, different chambers of larynx. What is the subdivision of regions of larynx? Very simple. Supraglottis, glottis, subglottis. How you divide this? What is that line? The superior line. Can you say? Yeah, next the glottic line. Yeah. So it's a horizontal plane from the lateral margin of the ventricle where it meets the superior surface of the vocal cord. Lateral end of the ventricle where it meets the superior surface of the vocal cord. That is the line A. Another is 10 millimeter below that line. So always remember that line A. So you all know that subdivisions, these are very important, subsides rather to say. Now, a very common question in MS exam is what is the embryological significance of larynx in the context of carcinoma larynx? That is a very common question you have to face. Anyone, can you say? You please. What is the embryological significance of CA larynx? Or mic odike ache. Embryological significance in context of carcinoma larynx? So, you all know that larynx develops from both sides, that is respiratory and the digestive. That supraglottis from arches 2 and 4, buccopharyngeal, and the glottis and subglottis is the 4, that is respiratory. So, that is arch 6, respiratory. So, there is a demarcation, and any carcinoma growth from the supraglottis, that will go superior towards that digestive side and laterally, and any growth from the glottis and subglottis, that will go towards the respiratory side, that is subglottic area. And what is transglottic carcinoma? Anyone? What is transglottic carcinoma? Yeah, very good. A tumor that crosses the ventricle vertically, upward or downward, that is transglottic carcinoma. And what are the routes of spread of carcinoma within larynx? Say a carcinoma in a vocal, right vocal cord, how it will spread to other side of the larynx? That is a very common question asked in MS exam. So, what are the routes? Spread of carcinoma, there are 4 ways of spread generally. Crossing the ventricles directly, once it reaches the ventricle, it can reach to the paraglottic space and it can go upward and downward. Then through the anterior commissure, through the paraglottic space, and posteriorly it can come down along the arytenoids and it can go to the post-cricoid space. But remember, the spread through the anterior commissure is not straightforward, because that ligament is attached there and it is a very tough structure. So, tumor either have to go upward and it can pass through the petiole of the epiglottis to the pre-epiglottic space, and there is upper staging of the carcinoma, or it can go downwards, there is rich lymphatic and tumor can go to the subglottic area. So, assessment of index subside from the history of disease progression, what I told at the beginning, that is temporal relation between the chief symptoms, that is hoarseness of voice, dysphagia, lump sensation, that temporal relation, which side carcinoma, what is the presenting symptoms, you have to know that thing. This all slides will be provided to you, do not worry. Imaging of the neck for the CA larynx, it is discussed, but go thoroughly for the CT scan. And very specific question is, how will you ascertain the cartilage invasion? Because once there is cartilage invasion, there is hardly any scope for preservation surgery. So, cartilage invasion identification is very important, and how will you identify the cartilage invasion? TNM staging, this is not a class for describing the TNM staging. I am emphasizing on the few points which you must know. You all know this nomenclature UICC. What does it mean, UICC? Union for International Carcinoma Control. Union for International Cancer Carcinoma Control, UICC. So, it is accepted. 7th, 8th, 9th, we are going through the 8th edition. It is very shortly we will go through the 9th edition. CTNM and PTNM, don't confuse. CTNM, that is clinical, that includes the radiology, imaging. Imaging is included in CTNM. PTNM is always after operation, PTNM. You all know the TNM staging, but you should know what are the limitations of TNM staging. That is the MS question, limitation of the TNM staging. There is 1.5 page in Stelmaran textbook, 1.5 page. What are the limitations of TNM staging? That is MS question. Cervical nodes in 8th edition, I am not teaching the node gradation, but there is a striking difference in the 8th edition for gradation of the cervical node, that is with extranodal extension and without extranodal extension. So, CTNM and PTNM it is different. You see 3B, any size with clinical extranodal extension. When there is extranodal extension, it goes to the 3B. Like the same also for the pathological node grading. So, treatment options of CA larynx. We have came almost to the end. What are the treatment options for CA larynx? Kar kache mic kache? Okay dao last. What are the treatment options for a diagnosed case of carcinoma larynx?
Surgery, radiotherapy, chemotherapy.
Chemotherapy, very good. You have only 3 options: surgery, chemotherapy and radiotherapy. There is a paradigm shift in the management of carcinoma larynx in over few decades. We do not prefer surgery nowadays. Once upon a time we are used to do the surgery. Surgery for the CA larynx is prognostically excellent. If you do the surgery in stage 1 and 2, there will be 100% disease cure, but at the cost of loss of voice. So, we do not prefer it. So, from total or open laryngectomy, it is shifted toward the endolaryngeal procedure and we move towards the organ preservations. Options as told, that is the radiotherapy, different modifications of radiotherapy, huge advances in the radiotherapy field. These are the commonly used chemotherapy, cisplatin and 5-fluorouracil and surgery. So, what are the options for surgery? What are the surgery for CA larynx? What are the options for the gold standard, and there is a total laryngectomy, then partial laryngectomy. It may be transoral, laser or cold skill, it may be codectomy, or it may be different types of open partial laryngectomy. So, open partial laryngectomy, it is not a very easy thing. Just remember what are the prerequisites for open partial laryngectomy. You cannot do open partial laryngectomy for every cases, because for laryngectomy or for open partial, some sort of aspiration is inevitable. So, you need a very good lung function for the patient. So, thorough clinical examination, pulmonary function, at least 60% of that expected age, FOL, at least one mobile cricothyroid retinoid unit, at least one mobile unit should be there, and no cartilage or extralaryngeal invasion. Then you can think of the open partial laryngectomy. So, this is a very common operation which is asked in MS exam. What is the total laryngectomy? It is called wide field total laryngectomy. Wide because it encompasses thyroid and the extralaryngeal muscles. So, it is wide field total laryngectomy. It was done by Theodore Billroth in 1873. He was not ENT surgeon, but a general surgeon. So, steps. Sorry. What are the steps for total laryngectomy? This is a very common question in MSc. At least we have to describe the stages. It starts with the preparation. Do not forget, the patient have to attend speech therapies. That is very important thing. Before operation, there should be some counseling regarding the speech. Routine investigation and lung function test is so important. Anesthesia depends on tracheostomy or not. Now, skin incision, what are the options? Skin incision, one is a Glaxorenson, another horizontal skin crease incision at the level of thyrohyoid membrane, starting from the anterior border of trapezius one side to another side. That is a accepted one. this type of horizontal incision at the level of the thyroid membrane. There is 2.5 centimeter circular for that tracheostome, and here should be at least 2 centimeter skin bridge. So, flap elevation suprahyoid and up to the supraclavicular level. Then mobilization of the larynx, you release all the muscles in the suprahyoid, do dissection in the paracarotid, do the neck dissection at least level 2, 3, 4. And thyroid, what will you do with the thyroid gland? Try to preserve at least one thyroid lobe depending on the inferior pedicles, at least one thyroid lobe. Mobilization of the larynx, then stoma creation. At that time patient will be apneic. When you are creating the stoma, you have to take out the endolaryngeal tube. So, ask for the 100% ventilation for 2 minutes, so that patient can have the oxygen reserve in the body, and you can work in apneic plane for 2 to 3 minutes, and within that 3 minutes you have to create the stoma. Generally we give incision in the tracheal ring adequately below the growth, and it is a oblique incision. Tracheal incision is a oblique incision that will increase the circumference of the permanent stoma. It is an oblique incision. Then you have to stitch the skin with the lower part of the trachea. It is called half mattress. Remember the term half mattress. Then entry into the larynx. How will you enter into the larynx? You do the dissection in the tracheoesophageal groove or tracheoesophageal party wall. Now you have to enter into the larynx. It depends where is the growth. If it is endolaryngeal, you can go from the post-cricoid space, but if it is supralaryngeal, then you have to go from the vallecula. After removal of the larynx, thorough was given. You have to take the new repair set and insert the nasogastric tube that will provide nutrition for next 2 weeks, and you have to think of the TEP, tracheoesophageal puncture, that is the speech prosthesis. Because of a shortage of the time, we can't go into that TEP matter. And myotomy, that is very important thing for speech. One is the TEP, that is tracheoesophageal puncture, and another is the myotomy, that is you put incision on the remaining part of the pharynx to release the circular muscle. Pharyngeal closure, either transverse closure or longitudinal closure, you can choose any one. Post-operative care, nasogastric feeding, how long? কতদিন পর post-operative? At least 7 to 8 days. Then you can try liquids. So, disabilities and rehabilitation, you have to know all the rehabilitation procedure, that is swallowing rehabilitation and speech rehabilitation and smell rehabilitation also. So, this is the summary, and I will ask next Dr. Shantanu Sheth for specimen part.
Okay, for the specimen will be a part of an OSCE. You may not face any questions regarding the specimen. So what will be there in the OSCE, the specimen will be there. There may be questions like, what is the specimen? You have to write down and describe the specimen in the papers, and you have to just give it. There is a very high chance that you will not face a question. Okay, now when you describe a specimen, what are the points you have to write in the paper? That is important. Now, all we know, this is a specimen of total laryngectomy specimens, but what is important that these are the points we have to note about when you are writing about the specimen. But most important thing, we miss the first adjectives. This is the important one. The first line, the weight mount. This is a weight mount specimen and it's an antemortem specimen. This is the 2 points you have to write down when you are writing a specimen. And you have to mention the name of the specimen. This is a total laryngectomy specimen. Then followed by what are the normal structures we can see in the specimen. That can include the epiglottis, hyoid bone, thyroid cartilages, tracheal rings, and then you go to the lesions. Don't utter or write ulceroproliferative growth. Just write down the growth or the mass in the site. Always mention the site. This is the common mistakes you miss. The site of the lesion and the extension of the lesions. Lesion can extend from the anterior commissure to the arytenoid. It is always a transglottic lesion. So you have to write down this is a transglottic growth extending from the anterior commissure towards the arytenoid on the right side or left side, whatever the lesion. And then you mention the opposite side is normal or not. So this is the way of protocol of writing the specimen when you just face the OSCE of a specimen. And the last thing is any notable finding means there may be a pre-existing tracheostomy to stoma is there. Mention that. Don't miss that thing. So these are all the points you have to mention when you write down the specimen. The next thing, the most easiest question, what is the solution? Formalin. No, not formalin. 10% formalin, that is the answer. What is the difference between formalin and formaldehyde? This is a very common question. Formaldehyde is the gas formation, gas form of this same chemical. When you make it in liquid, it is a formalin. So 10% formalin is basically 4% of formaldehyde. Okay? So this is a 10% formalin we use in the solution. Okay? And you have to know how these things are actually weight mounted, the specimen preservation technique. I'm not going to details. You have to keep the formalin in the formalin for more than 24 hours, and then before that you have to inject the formalin in the specimen to preserve. How this formalin actually preserve the specimen? Anyone? So this is basically is from the protein to in solid forms, and that's the help in the process of formalin to preserve the specimen for a long time. Okay. Any other solutions you can preserve other than formalin? There are alcohol, isopropyl alcohol, ethanol. These are the solutions you can preserve, and the best option to preserve a specimen is the liquid nitrogen. It can preserve the cellular characteristic. So the last question I will ask, how to open up the specimen. When you cut down the larynx, total laryngectomy specimen out, how to open and see the larynx? You have to cut in the posterior part, posterior tracheal ring, go up to the interarytenoid space. When you cut this thing, it will open up. That's the way to open up the specimen, and that's the way to preserve the specimen. When you are seeing this thing, it will be opened up specimen from the posterior part. Okay? That's all from the larynx, and these are the questions you can face in the OSCE. Probably you will not face any questions from the total laryngectomy specimen. If any external want to ask you, these are the questions you can face. That's all. Okay?
Thank you.